The next talk is by Professor Emery Brown. Emery holds a number of titles. He's an anesthesiologist who is at MIT as the Edward Hood Taplin Professor of Medical Engineering. He's also a professor in my department, Brain and Cognitive Sciences. He's a professor of computational neuroscience. He's also the associate director of the Institute of Medical Engineering and Science, also called IMES. In addition, he's the Warren M. Zapple Professor of Anesthesia at Harvard Medical School and the Massachusetts General Hospital. And so with all of that background and credentials, today Emery's topic is the brain in suspended states. Professor Brown.
So thanks a lot. Thanks a lot for asking me to share this with you. So I'm going to talk about the brain in suspended states, and that's a code word for general anesthesia. Okay, so we fit it into this sort of the same, kind of the same format that we've used up until now. So I'm going to go through this outline here. I'm going to give you a little bit of background. I'm going to tell you a little bit about why general anesthesia makes you unconscious. Can we wake the brain up from anesthesia? And then what I want to also do is give you some idea of what anesthesiology means for clinical neuroscience in particular, sort of a look into the future. All right, so just a little bit of background. So in 2005, science considered the question of figuring out how anesthesia works as one of the top 125 questions, one of the top 125 scientific mysteries. So every day, about 100,000 people receive general anesthesia and sedation to safely and humanely undergo medical procedures, primarily surgical, or diagnostic procedures. And there are a couple things which have gotten a lot of press recently, and in particular for the older population, this idea of the brain not working the same way after anesthesia. And, you know, as we get older, the likelihood of that occurring seems to be increasing. And on the other end of the age scale, the concept that anesthetics are toxic to the developing brain. And that's become such a major concern that the FDA has now entered into a partnership with the International Anesthesia Research Society to actually investigate this formally. So let's just talk about general anesthesia. So one of the things that I learned in working with my systems neuroscience colleagues, if you needed a good definition, because what anesthesia really is, it's a set of behaviors. And what we're trying to do, kind of along the paradigm that Jim laid out at the beginning, is to figure out how the brain is put into these states, how it generates these behaviors as a consequence of the drugs working on specific circuits. So the definition is a drug-induced reversible condition in which you're unconscious, you don't remember, it's not supposed to hurt, it's nice if you're not moving around while the surgeons are operating. And the other part is stability and control of the physiologic systems, because if you take these first four right here, they're all synonymous with death, all right? And on that long list of things that are not cool, that's major league not cool, all right? So one of the things, so just to give you some sense of what anesthesia is like, so how many people here have had anesthesia? Oh, well, Jesus Christ, yeah. Like an anesthesia club here, basically. All right. How many people have seen other people get anesthesia? Oh, well, I'm going to fix that for the rest of you now. All right. So this is going after this question, why does propofol make you unconscious? All right, so this is a gentleman that just one Friday afternoon, Eric Pierce and I, as one of my colleagues at Mass General, we just decided that what we would do, is just go over and film this gentleman who is going to have anesthesia. And he has a small hernia that needs to be repaired. He had surgery a few weeks back, and he needs to have this hernia repaired. It's a very short procedure. So I thought I'd just go over and just take a, and film what was going on, because we see it every day, but we don't see it, all right? So I'm going to have him do a few maneuvers, all right? So the first thing, I'm going to have him just track my finger. Okay, now I'm going to turn his head, just to show you something, all right? All right, so if you've never seen this before, this is the doll's eye maneuver, all right? So what it means is if I... Okay, so what it means is I turn your head this way, your eyes go that way. I turn your head this way, and your eyes go the other way, all right? So that's all normal in him, all right? Okay, I'm going to pull down. So now I'm just showing you he has normal motor strength. I'm pulling down on his arm here. This is how we bond with our patients before we start anesthesia in the morning, all right? So now what we're doing here, So the nurse anesthetist is taking care of him. She's actually giving him oxygen. She's going to breathe 100% oxygen for a little bit, because what we do is we try to remove all the nitrogen from the lungs so that if there's a problem, the person has 100% oxygen, and we have a margin of safety in case we have to, do some emergency maneuvers. What we're going to do is have him become unconscious and then place a breathing tube to take over his ventilation during the surgery. So that's what she's doing now. All right.
Before you go off to sleep. Deep breath in.
Deep breath.
And then forcefully blow
Breathe
it out.
in and breathe it out. Deeper
Another
in.
deep breath, as deep as you can, and blow out.
So I want you to just watch.
So right here, where the words come on
You
the
may feel
screen,
warmth in your
right there,
arm.
we just gave him a bolus dose of propofol, 150 milligrams, all right? So this is real time, it's not edited. We'll just show, let's watch what happens. Watch his eyes.
If you can no longer do it, just fantastic. Just keep doing it. Just keep doing it. That's great. Good. If you can no longer do it, just tell me.
So his eyes are fixed in the midline now, all right?
Sir? Sir?
I mean,
can
I
you
knew
hear
he
me?
wasn't going to respond. That's just for effect. All right.
I'm just going to give you a deep breath here, okay?
All right. So look at him now, all right? Look at his eyes. They're fixed in the midline, all right? All right. So, I mean, his eyes are fixed in the midline. He's not breathing, and he's actually not conscious either, all right? Now watch his arm. Watch this. So his arm is like spaghetti. So all of that just happened just by giving him this bolus dose of propofol. So 3 very profound effects. So right here, stopping breathing, losing his muscle tone, and then also becoming profoundly unconscious, all right? So one of the reasons that it really troubles me when we hear people say that we don't understand what anesthesia works, it means that they haven't done this little exercise that looking at something like this and then what I'm about to explain to you now, which is if you think about how the blood gets in, the anesthetic goes into the bloodstream, and when it reaches the brain, it comes up through the basilar artery. So the basilar artery runs on the underside, like right here, and as it moves along here, it deposits the propofol in these various areas. Well, the first place it hits are the respiratory centers, which is sitting right here, and the way propofol works is it enhances inhibition. So if you have a network of neurons which are excitatory and inhibitory, if it pushes everything towards inhibition, then that center will shut off, and that's exactly what you see. People stop breathing. Now, the next part, which is right here, why does the gentleman become unconscious? Well, we had an overt sign of that. At the time when he was becoming unconscious, what we noticed was his eyes stopped moving. So when neurologists look at the eyes, they could sort of care less about the eyes. What they're trying to do is make an inference. They're trying to make an inference about the centers that sit around the eyes. And what sits around the eyes, which are these other colored dots that I have here, are the arousal centers. And these centers start in this area of the brainstem, which is primarily the midbrain and the pons, and they project upwards, and they provide the major inputs, the cortex, the thalamus, and sort of other subcortical areas to sort of keep us aroused or keep us awake, all right? So now, it turns out that they also have a rich array of inhibitory neurons there. So once again, as the drug hits this area here, it switches everything to inhibition, so it turns off these arousal centers, so it's not surprising that the gentleman loses consciousness, all right? And then here, the overt manifestation of that is because the nerves that control the eyes, the 3rd, 4th, and 6th cranial nerves, actually come out right at the same part, the same location where the nuclei are sitting. So losing the control of the eyes turns out to be kind of a clinical manifestation of someone losing consciousness in this particular case. And the final point is why the person becomes sort of flaccid like this. I put this other diagram here because NASA's interested in this. Now, the astronauts often have the same condition. They're very flaccid when they come back from, they don't hop out of the space shuttle and say, hey, that was one hell of a great space ride. I really enjoyed that, right? Because when they come back, they're actually they're like this. They're limp because they've been in 0G for an extended period. So it turns out that a very interesting observation, clinical observation in motor control. If you take out these 2 relay nuclei, which sit in the same area there, the pontine reticular nucleus and the medullary reticular nucleus, you actually get the same phenomenon of a flaccid paralysis. And one of the reasons we know this is that just from a clinical observation, when patients end up with a clot that blocks the basilar artery here, and it gives them what we call a pontine stroke, we actually see the same phenomenon. They don't present spastic like you normally think of patients who've had a stroke. They actually show up with a flaccid paralysis. All right, so right there, we deduce a lot of things about how the drugs could be working. But one of the things I want to point out to you is we use the EEG extensively, both in our studies, as well as now, at least at Mass General there, in patients in the operating room. And one of the things that we're actually teaching our residents and teaching the staff to do is to read the EEG under anesthesia, because you can actually have a monitor of what state the brain is as a consequence of being under anesthesia. And this is what I want to point out here. This is one of my patients that I was taking care of in the operating room. It's not the gentleman I showed you, but I just want to point out two very obvious patterns that you can see here. This is a frequency spectrum, so this is frequency on this axis, this is time on this axis, and then this is on a decibel scale, so it's a log scale. And if you look right here, this is low frequency, and this is what you see when someone goes off under anesthesia. You see this very strong low frequency oscillation, which is generated almost instantaneously. Right? Then, if you maintain, in this case, the infusion of propofol, what happens is you see two very strong oscillations, one at about 10 cycles per second and the maintaining of the slow oscillation. So it looks something like this here. So you have those two things. So key point, slow oscillation, 10 hertz oscillation, which are very robust signatures of someone being profoundly unconscious when you're under propofol anesthesia. So what I want to do is just give you a little sense of what we've learned as to why these phenomena exist. So we've done a series of studies, and we're just going to share some data from one or two of them with you, where we've given people increasing doses of propofol and then decreasing doses, and we've measured high-density EEG while we have the patients perform a behavioral task. Every 4 seconds, they have to answer a yes-no question. Okay? So when they stop responding, we have a very good sense of when they've lost consciousness. Now, let me explain one phenomenon that occurs here, because it gives you a real sense of what happens to the brain in terms of the EEG when someone becomes unconscious. There's this phenomenon called anteriorization. What anteriorization means is if you put electrodes here in the back of the brain and you record the EEG, you'll see a very strong alpha oscillation, a 10 hertz oscillation, if you sit there like with your eyes closed like this, all right? Now, what's going to happen as you lose consciousness, that alpha oscillation is going to move from the back of the brain to the front of the brain. When you're profoundly unconscious, it's going to be in the front of the brain. And then when you let the person recover, it's going to move to the back of the brain. All right? We can track that by looking at the spectra here. So these are the spectra of someone in this subject I'm going to show you. This is the 10 hertz oscillation right at the start. This is the entire study here. 10 hertz oscillation at the start. They get drug. It increases. It decreases. The oscillation disappears in the back. The 10 hertz disappears. When the drug decreases and the person comes back and regains consciousness, it reappears in the back. Whereas up here, what you basically see is it disappears. It's not there at the beginning, and it appears when they're profoundly unconscious, and then it disappears again once the person regains consciousness. So I'm just going to show you this in a little video. So this is the front of the head. This is the left. This is the right. Here's basically the back, all right? So the person has their eyes closed. So here's this 10 hertz oscillation sitting in the back there. So I start this here, and you can see here as the drug dose is increasing, so not getting anything yet. Now right here, they start getting some of the drug. This is propofol, getting this infusion. And you see how it starts to fade out here in the back. And now you start seeing it appear here in the front. Okay, there it is, very strong. This isn't even the deepest level. I'm going to stop this right here. And if you look, you see the pattern is actually over this part of the head. That's going to be important for what I tell you subsequently. And if you look back over here, there's a different dynamic across the back part of the head. All right, so I'll just play this forward. All right. All right, so here is the most profound level, the highest drug concentration when you get to 5. All right. So now what we do is we back it back. All right, decrease it. And you see that it reappears back here in the back, and the subject actually comes to. All right, so what just happened? Let me just tell you what we figured out. All right, as I said, propofol works by inducing inhibition across the brain sort of globally. And one way of thinking about this is that the brain is this very, very high-dimensional dynamical system, and what you're doing with the propofol is you're sort of pushing that forcing function, which is on the right-hand side of the equation. And what it does is it pushes a very high-dimensional system down to lower dimensions, all right? And those lower dimensions are very, very obvious. They turn out to be slow oscillations and alpha oscillations, okay? And one of the reasons that we've come to appreciate this is that the thalamus in our imaging studies, like the fMRI studies like Drazen and Rebecca were talking about, they actually show that the thalamus, which is the central way station in the brain, turns out to be active, all right? And then at the same time, what you see is this pattern across the front of the head of this 10 hertz oscillation. And the key thing about it is the 10 hertz oscillation is tightly coupled across the front of the brain, all right? So using that, we did some mathematical modeling with the help of Nancy Capel, who's one of my collaborators at Boston University. And what we're able to deduce is what's probably occurring is the thalamus, which is active, and the cortex, to which it's richly connected, are in an oscillation, a disruptive oscillation. So it's something like this. I'm talking to you, and you say, okay, this is great. You know, what I want you to do, though, is take what you're telling me. So my voice has a lot of frequency content in it. There's some high tones, low tones, this sort of thing, all right? But you say, okay, Emery, give me the same lecture, but what I want you to do is you get one frequency, a very narrow frequency band, and you got to keep the amplitude the same. So all of this becomes okay? So, right, okay. You laugh, right? But I hope your anesthesiologist looks for that when you're under anesthesia, all right? All right? All right? So that's what we think is occurring here with this 10 hertz oscillation, all right? And the key thing is this is observable in patients in the operating room. Now, let me just tell you about the slow oscillation. And like Rebecca was saying, you know, we don't have situations where we can put electrodes in volunteers, but we do have a unique situation where we have electrodes in human brains. And these are patients who come to Mass General to have epilepsy surgery. They have intractable epilepsy. It's been going on for a long period of time. The drugs are not working. So they're coming to have surgical removal of the area of the brain that's responsible for the epilepsy. So they come in, the neurosurgeons implant electrodes, then they stay in the hospital, they seize for a period, off medications, we figure out where the foci are, where the seizures are occurring. Now they come back to have a resection. So they come back to the operating room, they have electrodes in their brain, they need anesthesia, so it's a natural setup to do an experiment under anesthesia and see what happens to the brain. And one of the things that we've been able to figure out is that we've been able to deduce what seemingly is going on with these slow oscillations. Here's an example of them, and they have two features in them. All right? So here are two sites in the brain marked red, green, and blue. The red and the green sites are close together. And so at those points, the slow oscillations are very much in phase. As soon as you move a short distance away, the slow oscillations are out of phase. When that occurs, the slow oscillations seem to be gating. So these are neural recordings. That's what these little blips here indicate, sort of histograms of neural recordings, where the neurons in the brain were firing when the person was profoundly unconscious, when the slow oscillations were there. All right? So the slow oscillations seem to be this marker for what the neurons are doing, or sort of telling or gating the neurons and letting them know when they can fire. So what we found out was, unlike the 10 hertz oscillation, which is tightly coupled across the brain, the slow oscillations are basically quite disconnected. It's just sort of like the top of the ocean, which is just sort of going up and down. So what that means is the slow oscillation is like a marker for fragmentation, watching the brain sort of the cortex being broken up into different pieces. So why does that matter? So again, this diagram here is actually from one of my patients that I was taking care of in the operating room. Now, you don't hear about anesthesiology until something bad happens, right? You know, the dumb anesthesiologist, the guy was awake, you know, and he didn't realize it, and he reports after the fact that, you know, that he was aware during the entire surgical procedure. There's no reason for that now, because you can see that these oscillations, they're not subtle. And to give you some idea, if you're sitting here like right now, if I look at the amplitude of like your EEG, it's about 5 microvolts or so, right? Under anesthesia, that goes up to between 20 to 50 and sometimes 100 microvolts, all right? So it's very, very obvious. It's very, 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 very non-subtle. And once you put a little physiology with it, it's quite easy to understand basically what's happening, right? So these are the things I've told you. A disruptive hum, cortical fragmentation. I showed you how the brainstem is inactivated, and what we should do is try to teach anesthesiologists how to read the EEG. And my feeling is that, brain monitoring should be a standard, in anesthesiology. So I'm just going to push this last part here. So how does the anesthesiologist view? I mean, you've seen the New Yorker view of the world, right? There's New York and then there's just a little bit of the United States left. So this is kind of like the anesthesiologist's view of the world. So it turns out that by studying general anesthesia, we can actually learn a lot about very, very fundamental things within the brain, right? Because 100,000 anesthetics happening daily, it's an incredible empirical laboratory that's really not being taken advantage of. And the reason it's not being taken advantage of is because anesthesiologists do not know neuroscience. Our training is predicated on pharmacology and just physiology, and you can get a long way that way. But for example, there are insights into anesthesia which can help us understand how to treat depression using drugs like perhaps propofol or maybe even ketamine. No drug, which is marketed now, allows you to have natural sleep. No drug, right? But there are anesthetics which we use which actually come much closer to producing natural sleep than anything that's marketed for sleep, right? The other thing is pain control. A lot of the work on trying to treat pain works on sort of from the brainstem on down. But one of the things we often see in anesthesia is we know that if we change your level of arousal, we can significantly alter your ability to tolerate pain, right? Drug overdose, a lot of insights into how that might be treated by using drugs which can actually wake up the brain. And then finally, or penultimately, medical coma. Medical coma is really just using an anesthetic to put the brain in a very profound state of inactivation. And it can be controlled very, very precisely using sort of engineering ideas that people at MIT are quite practiced at. And then finally, aging. Something that affects everybody, all of us here. And, one of the things that we've started to appreciate is perhaps the circuits that people are looking at to try to develop drugs that help us improve cognition or help us age typically and maybe reduce the effects of certain things like dementia or Alzheimer's. Perhaps they're looking at the wrong pathways. And these are insights which we've gained from looking at the brain under anesthesia. So if anything, the neuroscience of anesthesia, by improving it, is going to help us take care of patients, I think, who need anesthesia care. But I think the more important, and I think the larger frontier and the larger contribution of this work is going to be to help improve the other areas of clinical neuroscience from which anesthesiology is currently disconnected because we don't view the brain, we don't view anesthesiology as a neuroscience discipline. Thank you.